Let's get started. Welcome everybody to today's community forum. So we have two presentations, N3C PPRL matching methods by Shaun Grannis, and be good to see how that's coming along, and monthly Recover Long Island project team updates by Emily Pfaff, Melissa Handel, and Richard. And next slide, please. And so upcoming presentations, next week is Independence Day. And after that is Logic Liaison template updates. And following that is the unit harmonization and values of quantitative data elements in a very large nationally pooled EHR data set. So this is the famous unit harmonization work that Kate Bradwell and Richard Moffat will be presenting, and that's been I think it's a great effort. I guess I'm conflicted because I'm on it, but I think it really is a really nice methodological contribution. And then July 25th, vaccine effectiveness domain team updates and monthly Recover Long COVID project team updates. Next slide. So we're up to 5.5 million COVID positive cases, 14 million patients or subjects in the enclave. Next slide, please. And so we're going to start with Shaun. So you can share your screen.
Sure. All right, let me just click through all the windows I have here and get that started. All right, let's see what we get here. Can you see my screen?
Can, but it's sort of small.
Okay. Do you see the slide deck or the entire screen?
Oh, the entire
screen.
Okay, let me, I chose the wrong one then. Let me start again. Let me see, there's the PowerPoint. There we go. Share the screen. That's, you know, I normally don't have difficulty with this. I'm trying to click share and it's not responding. No matter what screen I try to share, it's not letting me share.
Dr. Grannis, would I help if I share my screen? I have your slides.
Sure, that would be great. Yeah, I've never had this happen before. My apologies.
Okay, just.
All right, are you able to get that into slide mode here, or do you just want to have a side by side? There's a slideshow button over on the right side. It says slideshow there. All right. And it looks like the formatting's a little bit off, but of course today we're going to be talking about the PPRL matching methods. My name is Shaun Grannis, and I am the lead at Regenstrief on the linkage honest broker work. Of course, many of you likely know Dr. Umberto Tacchinardi, who has led this initial round of work and want to make sure that, you know, Umberto is recognized for the work he's done here. I do a lot of work in patient matching and record linkage. Until about 5 years ago, it was largely identified, but of course, as many of you know, we've moved into that privacy preserving or encrypted or hashed or whatever terminology you use. What I'm going to do today, my primary goal with the presentation today is to show you current status, how we're matching, and then some statistics for that system. And then of course, answer any questions that you might have. Why don't we go on to the next slide? There we go. So just some overall characteristics of the N3C model, and this may be well known to many of you, but just to make sure we're all on the same page, the sites create tokens, crypto hashes from protected health information, and the data goes into the enclave without the PHI. We use those encrypted tokens. Those tokens come to Regenstrief, to our linkage honest broker system. We leverage the governance rules set up by the N3C to define how this works. We work to deduplicate tokens. We provide a map for data linkage and re-identification by the sites. And we keep records of all the transactions for auditing purpose. So that's a high level overview. And again, lots of details we can go into in question and answer. Next slide. So we use unique patient keys. The sites use Datavant software, which generates irreversible hashes. The sites encrypt those hashes, and the governance for the intended recipient of those hashes can be managed by controlling who sees which tokens. There's no protected health information that's sent out, and this has been determined by expert determination to be de-identified, and we have independent certification of that. Setting up the software is fairly quick. This provides accelerated IRB determinations in many cases, and it helps accelerate data sharing agreements. So that's an overview of why we're doing this. Next slide, please. So the general process, we have two general swim lanes of work. Number one, we have token ingestion. So the site, upper left square, site submits a token. The linkage honest broker, that's Regenstrief, ingests it and converts it to linkable tokens. And then we at Regenstrief evaluate the site-specific token data quality and provide feedback to the site as needed. On the matching front, we run the matching algorithm weekly to generate those linkage maps, including duplicates and cross-site linkages. And then we generate site-wide statistics as well. Did I hear a question? Or just maybe some echo? Okay, thank you. Next slide. So, want to walk you through the basic logic for the match algorithm. We had developed an initial draft prototype version that we evaluated and modified. That initial version used slightly different logic using an OR function. And what we've done with our version 1.0, which is production, is we're using what sometimes is called a waterfall method. What the rules are, we review token matches in the specific order listed in that white square at the bottom of the slide. And each token combination is considered in order, starting from the highest level downward. And so when neither record has the token available, we will proceed to the next token to evaluate. Once a record is considered at a level, if it has both tokens present, it will not be considered or evaluated in subsequent levels. So if token 16, if both sites have social security number and first name present, such that that token exists, but those tokens disagree, we are done with the match. We will not attempt on any other tokens. It's a fairly conservative approach that we've adopted since based on lessons learned from the prototype version. All right. Next slide. So here are the current match counts. So there was, I quickly checked the statistics that were mentioned earlier. Currently, we have on the left-hand side, that 5.9 million is the total number of identity records that we received, total number of records with tokens. The upper right side shows you how many deduplicated or unique patients we have. And that's right around 5.9 million. There's about 37,000 duplicate patients that we've identified in the system. And then the second row shows the agreements, the data transfer agreements, the linkage honest broker agreements. So you can see that we're continuing to work through getting folks signed up there. And so that's the overall statistics at this point. Again, I recognize that I'm going fairly quickly, but I wanted to make sure that processes like these, often people want to sort of touch the elephant at different places. So I'd rather we get through the presentation and then be able to ask questions. Next slide. So we have built some statistics. There's a new spelling of statistics for us to evaluate token quality control. So what we've done is we've generated completeness and cross-site linkages based on token combinations. So as we began this process, one of the things that we did, we're going to use an example here, site 1. By the way, we've de-identified all of the sites for this presentation, so we're not going to name any names in this presentation. But site 1, which was a site we took a look at, we identified they sent 1.7 million records to the enclave, and we understood them to have around 244,000 the previous week. So we saw a significant increase in just the volume sent, so we needed to work on that. We looked at both within site linkages. And we looked at each token to see how many linkages were produced by each token. And we looked at across these tokens, one of them had a very high duplicate rate. And we hypothesized very likely, and some of you know this, we can see filler information or default information put in a field. And often for cell phone, there can be a filler information. And sure enough, that's what we learned from the site. They had been sending filler information. But again, it was being able to look at within site duplicates and getting a sense of that seems like there's significantly more than we would expect. We also observed with this site that they had 0 social security number fill rate. You can see from the blue squares there, all of the social security number tokens. You can see which fields were used to create a token. All of them had 0% fill rate. These statistics on this page are the fill rate. What percent of the records that we receive have this particular token completed? After working with the site, we were able to address the issues to ensure that the number of records came down. We were able to identify that social security number had not been included, and that was included then. And you can see that the token fill rates increased significantly. They eliminated the phone number filler data, and we were able to correct those issues. So this is one example where even though it's de-identified, we can make some inferences about the data to understand its quality, its completeness, and its accuracy. Next slide, please. So this was an initial run prior to before we started site outreach. So run one was a data quality metric generation process prior to developing our process to work with sites, communicate with them. And so these were the initial statistics that we were observing. So again, we saw missing tokens, missing fill rates, etc. So what you'd like to see on this slide is no color whatsoever. You just like to see white on here rather than the yellow or the blue or the red, which indicate different levels of missingness. After working with these sites to address these issues, go on to the next slide, please. You can see that the number of colored slides, particularly in the middle region, were addressed. And so we were able to increase fill rates significantly by targeting lower fill rate tokens. So we'll go to the next slide here. So these are the cross-site clusters. So we're looking at, we count the number of linkages we see across sites here. And you can see in the leftmost column, we have site one has two entries. One entry for clusters of two, so two identities were linked together. And then we had site one had some clusters where three entities were linked together across external sites. And so you can see the statistics there. And so we evaluate these numbers. We dig into why we might be seeing these types of numbers to confirm whether or not this makes sense. Is a site geographically proximate to another site to explain perhaps the larger cross-site clusters? So again, this provides us with great information. We actually track the change over time. So if we see any significant changes from week to week that are unexpected, we can target that. So this is cross-site clusters. Why don't we go to the next slide? Where we can see within site clusters. And again, here we can see, we'll take a look at site 2 here. Site 2, this is internal now. These are just internal duplicates. Site 2 had 3,500 internal 2-record clusters. That seems like a lot. Well, we know what's happening at that site. It is a system that captures multiple identities for the same person. And so by default, that site is sending us duplicates that we need to deduplicate ourselves on this side. So again, we understand we want to validate and look through each of these cluster sizes to make sure they seem to make sense. So generally we see fairly small cluster sizes, a few of them we see larger, but these give us information about whether or not the data we're receiving makes sense, whether the algorithm is functioning as it should behave based on what we understand background duplicate rates to look like. All right, next slide.
So actually, I think an important question. So David Sarner asked, how are clusters defined?
Sure. So a cluster would be a record from one site, from site A, links to a record from site B. If there's only 2 records involved in that, that is a 2-sized cluster. If a record from site A, 2 records from site B, or a record from site A links, that same record links to site B and site C, that would be a 3-record cluster. So we count the number of identities that are either internal duplicates or cross-site linkages. And we know, and many of you who probably have done a lot of matching know, internal duplicates happen, the data quality for internal duplicates is actually different from cross-site linkages. You should on occasion see cross-site linkages. Internally, unless the system explicitly defines that it will have multiple identities for the same person, we shouldn't see dupes. And so duplicates actually occur due to a failure in data quality, a failure in workflow, a failure in other intentional business processes that weren't successful. And so that's why we want to look at internal versus external clusters differently. Did that answer the question? I'm happy to say more.
Yeah, no, I think that's great. Thanks.
Okay, very good. All right. So where are we with next steps? So our version 1 reduced the overmatching that we saw in the pilot method. We've increased the token fill rate and enhanced customer experience. I didn't spend a lot of time talking about this, but our team weekly generates automated data summaries for each site, and we share that with the site. So if the sites are interested in understanding what their data is showing, we can share that with them. If they see anything unusual, they can share that with us. We typically are identifying those questionable metrics that we want to work with the site on, and we'll send that back to them and establish a conversation. The third to the bottom bullet here, we actually offer office hours on the first and third Thursday of the month at 11 a.m. Eastern time for folks who want to just hop on and discuss their data or better understand the process, what's happening. They can do that with the team. And so we've built some of those feedback loops in. See what else. I think I've mentioned most of this. We're directly communicating with sites. We have an automatically generated email once we receive the tokens. And so again, we've really started operationalizing the process and monitoring and tracking. So those are, I believe that's the last slide. I wanted to run through this fairly quickly so then that we can see if there are any other questions that we have. Again, went through it fairly quickly, I know, but there's so many details we could go into that I want to hear from the group what questions they might specifically.
Oh, thanks. That was a great high-level summary. So Hannah Blue, to everyone, how did Site 2 have so many clusters of what seemed like large sizes?
Sure. I promised I wouldn't name sites, but I will tell you that this is a health information exchange that gets to capture identity for each individual at each organization. So if a person is seen 10 times, if the person is seen at 2 clinics, 3 emergency departments, 4 hospitals, they have an identity for each of those if they're distinct organizations.
Okay.
Those higher clusters are actually real clusters of people who are just seen at different organizations within that site.
Okay, no, that actually sounds like that could be a fairly common use case. So maybe if you could talk about, so you went back to the sites and iterated with them to improve the fill rates. So what mistakes were being made? So why was Social Security so infrequently, properly, why did you initially get so few tokens from Social Security, and how did you improve it?
Yeah, so often, the answers to these questions are fairly straightforward. Initially, the individuals did overlook the fact that Social Security number was not being sent. I mean, when we put together all of these extract, transform, load processes, and you're dealing with multiple fields and multiple tokens, I think it can become very quickly combinatorially confusing to people. And so a token might be overlooked. And again, without generating these statistics, we may not have observed that. There's so many numbers to look at, but I think we've built a rational way of identifying that. So there can be overlooked fields that just aren't being sent. Sometimes there can be missed data. So for example, we saw some fields where some tokens where across the board for every token, say with zip code, we were seeing lower fill rates. We talked to the organization, they say, oh, that's right. We actually have to grab zip code from this other file, put that in because our primary file is incomplete. And so we can actually find not only just the completely missing, but we also look at where fill rates should be higher than expected. So typically things like last name, first name, date of birth, sex, even zip code tend to be fairly well populated most of the time. Zip code tends to be a little bit lower because it's not necessarily one of the prime fields, but we know what fields are generally collected fairly completely. And when we see something outside of that pattern, we want to investigate it.
But then, so operationally, you're working with particular Datavant in particular. So correct me if I'm wrong, but I mean, we've been involved in this too, obviously. So each site obviously has to install and then feed data to the software, which generates these things locally.
That's
so
right.
Then what you're essentially, tell me if I'm correct, so you're essentially saying is that one way or the other, the initial attempt to feed data to the tokenizer, if that's what you call it, is only partially successful. And then you have to go, by generating these statistics, you go back to sites and say, for whatever reason, Social Security and whatever numbers and whatever haven't been necessarily, fed to the token generator, and then you get back to people and then they make sure that happens.
That's
Is
right.
that
And
correct?
I don't know if Jasmine is on or if she can talk, but Datavant software does also generate alerts as tokens are being generated to identify areas where tokens might not be completely generated or missing. And I don't know if Jasmine's there that she can say something about that as well. But the Datavant software does help identify that. But again, sometimes things just fall through the cracks.
Yeah, no, that sort of feedback is really, I mean, what you say makes a huge amount of intuitive sense. I mean, in pretty much every process one can imagine, having feedback loops is critical. I know the vocabulary data ingestion groups do that. All right, well, this was fantastic. Any last questions? We should get on to the next thing. Well, thanks. That was actually a very interesting presentation. I really liked it because it was very concrete. Got a very sort of granular ideas to what you're actually doing, which was nice.
Good. Thank you.
Thanks.
Yeah.
Okay, so Emily, Melissa, Richard, who's up now?
I am going to share the slides, and Melissa and I are going to tag team today. Can you see the slides?
Yeah.
Yep. Okay, great. So we are going to do our monthly Recover update. I think we have a relatively brief update today, but some exciting developments. So I'm going to start off with an update on the machine learning model that we've certainly talked about before on this call. And the update is we've shifted our training data a bit now that the U09.9 diagnosis code is available and has been available since October 1st of 2021. By no means is it available at all N3C sites, but there is a critical mass now of N3C sites that are using U09.9 to code long COVID in clinic. And because of that, the amount of training data for the U09.9 patients has dwarfed the amount of training data available for our long COVID clinic patients. And so for our main production model, we have shifted over to using training data from U09.9 patients specifically. And what I wanted to talk about here was just what effect that has had on the model itself and the most important features of the model. And the answer is it didn't have a ton of effect. And actually, I think that's a good thing because we want stability in the most important features. I think that validates a lot of the work that was done when we were training on long COVID clinic patients. But the most important features are very much the same as the long COVID clinic patient model, including age, dyspnea, fatigue, how often you go to the doctor, albuterol, etc. However, I think that some additional features did sort of rise a little higher in the list than they were before in the long COVID clinic model, such as palpitations, for example, tachycardia, and a couple of GI issues. And these are things that you do see reported as, hallmark symptoms of long COVID. And again, whenever our model matches common sense, we see that as validating. So right now, I actually ran this a couple of weeks ago now, but basically we have about 150,000 patients in N3C that are getting high scores on this model. And what a high score means is that the model thinks it's highly likely that that person may have long COVID based on what it's learned from the UO9.9 patients. And so we continue to work on this, and we're very pleased with it, and we do hope that it can be used as a clinical trial recruitment aid in the near future. The other thing I did want to mention is something that we've maybe not spent a ton of time talking about on these calls, which is that there was a code for long COVID prior to UO9.9's release, and that code was B94.8. And the reason that this is important is really illustrated by this visualization here, where you can see now, of course, this starts in 2018, which was well before the pandemic. But the reason that this starts in 2018 is because B94.8 is a generic code for sequelae of infectious disease. So you can see that B94.8 has been used as a code, albeit somewhat rarely, over a long time, well before COVID became a thing. But then in 2020, the CDC recommended that B94.8 be used in addition to its prior uses to identify long COVID. And so you can see that from a relatively rare usage, it starts to creep up and up and up and up to a great extent, in fact, until in October of 2021, UO9.9 was released. And so I think this is a really instructive visualization for people who are trying to determine how COVID is, or how long COVID rather is coded in the EHR, if it is coded at all, and is something that we need to keep in mind for future work. And again, if you are looking for long COVID patients in N3C or in any EHR data, looking at B94.8 is a really smart choice. The last thing I'll mention is that we don't want to only use these codes to identify long COVID patients, because we believe that the uptake of UO9.9 was slow. We still don't have all of our sites using it. So right now we have 36 out of our 74 today N3C sites using UO9.9. And we just know that we're going to miss a ton of patients with long COVID unless we combine UO9.9 with alternative patient identification methods. Okay, so now I'm going to talk a little bit about vaccination and long COVID and the work that's being done there. And I should specify that this is not work that I am leading, but I am merely reporting the great work of other folks. But I want to repeat something that I think we've said on this meeting before, which is that determining who is vaccinated is difficult in the N3C data, just because we as N3C receive data from EHRs, which are not necessarily updated terribly regularly with things that happen outside of the healthcare system that owns those EHRs. So we get the information that we get, but that may not be inclusive of all important information, particularly regarding vaccine status. And so what we needed to do in order to actually do really complete good analysis about vaccination is determine which sites had the most complete vaccine information. And the reason that's important is because you need to know something about completeness in order to determine who is unvaccinated. Because if you have incomplete data and you say everyone that does not have a vaccine record is unvaccinated, you may be mislabeling people who simply are missing their vaccine data and are not actually unvaccinated. And we certainly didn't want to do that. So very creative method that our vaccine analysis team came up with to look at CDC county data for the CDC's estimate of what percentage of any given county was vaccinated at different points in time. And that ratio was compared to the amount of individuals or the proportion of individuals that we see in N3C in that same county that are vaccinated at any given point in time. And what the analysis team did was actually make a ratio out of those two measures, and that enabled them to define a trusted vaccination site for any site that had a ratio that is at least 0.7 between the CDC's estimate and N3C's sort of catchment of vaccine data. 9 of our 74 sites met that criteria. That sounds like a small number, and certainly more would be better, but there's a lot we can do with those 9 sites. It's a lot of patients. And that's one of the advantages to N3C, is that even if you don't have all the sites, you still have a very large sample size. So we're very much looking forward to using these data. You may have even seen in the media or on Google how conflicting the information is right now, at least about what effect, if any, vaccination has on long COVID risk or long COVID outcomes. I ran a Google search for vaccination and long COVID, and just on the first page of Google results, there were 4 results that were at the top that said 4 different things. And that's very confusing and difficult to deal with. And so our vaccine analysis team is working to use the N3C data to do a similar analysis. And in fact, we have also come up with conflicting results depending on the methods that we use. They are continuing to refine those methods. And right now, it does seem like our winning method, although certainly this is a work in progress to a great extent, shows a small but significant protective association. So maybe nothing to write home about, but it's certainly not, it does not seem to be anti-protective at least. And I suppose the current wisdom is that it's either neutral to tiny bit protective, but we will certainly update this group when we have better information on that. I'm going to turn it over to Melissa to talk about risks, interventions, and outcomes.
So I'm going to talk about one particular intervention that government agencies had asked us for data on recently. And it was really exciting because we had a significant group of people really rally at the last minute to try to put this information together. So I want to thank them all here because it was a heavy lift on short order. Andrew Gervin, Chris Shute, Emily, of course, Hytham, Josh Fessel, Julie McMurray, Ken, and Leonie. So thank you guys for working with me, and it was really a pleasure in the middle of the night. So middle of the night data here. This example is Paxlovid. It turns out N3C, despite not having an enormous amount of Paxlovid data, has more Paxlovid data than most anywhere else. And so that's a really insightful place then to look at Paxlovid. And this will be the first of, I think, what will be a number of different installments as our risks and interventions group really finalizes some of the first set of analyses. So stay tuned for our next update on some of those details. So here for Paxlovid, we basically have a number of different patients who have a COVID-19 coded visit post 5-day course of Paxlovid over on the left. The right most diagram are patients that have any visit post Paxlovid. So we're just really looking for patients who have come back to the clinic, but it doesn't have to be a UO9.91. And the reason those are so different is because some of the patients that have other visits are coming back for all kinds of other things. Maybe they're coming back for a mammogram or for a drug pickup or things like that. So we wanted to kind of narrow and try to understand what's happening to patients post Paxlovid to see if we were seeing the rebound effect that has been potentially reported. And so you can see on the left one, the cumulative percentage of Paxlovid treated patients with a subsequent COVID-19 related visit. And then, so we're looking for patients that have a COVID test in that period in the 3 weeks post Paxlovid. There are not very many patients here for which we have COVID tests similar to our vaccine situation. Patients test at home, they test at Walgreens, et cetera. It's not necessarily in their EHR. In this case, we have 57 patients who tested positive for COVID post Paxlovid, 12 that tested negative post Paxlovid, and 769 that had an unknown status, but we did have a COVID-19 related visit in that 3-week period post Paxlovid. And so you can see there is a pretty big difference, even though the numbers are very, very small. And I'll show you some of the kind of particulars on the next slide, please. And so this is really looking at what are some of the new diagnoses or continuing diagnoses. And I'll talk a little bit about what some of our future work might look like. But again, this was done in a hurry in the middle of the night. So we just have some early indications here. But essentially, we looked at, so here we have, just over 14,000 Paxlovid patients. So, and we looked at new or continuing diagnoses in that same 3-week post-Paxlovid period. And you can see on the leftmost column are our 100 positive patients. In the middle column, we have our 111 negative COVID patients, and then the ones that we don't know the testing results for, with the density being darker, meaning there's more diagnosis in that population. And so what you can see is that we do see a higher higher percentage of patients with pulmonary and urinary and kidney features in the positive COVID patients post-Paxlovid than in the negative ones. Again, the numbers are very small here. You can also see some interesting things like the fact that we have essential hypertension in all the populations, which is probably representative of the percent of the population writ large that actually has hypertension, but we have not done that analysis more carefully yet. The takeaway here is that there appears to be a moderate increase in pulmonary and urinary and kidney diagnoses in COVID-19 positive patients who've been on the who are post-Paxlovid treatment. So we don't, of course, know yet what this means for long COVID, as these patients have not been in the system long enough to have developed long COVID. But it is an interesting way of kind of thinking about things. One of the most important things that we really need to do is to understand which of these diagnoses, and also looking at lab values, as well as other medications and interactions with other medications, both before, during, and after the Paxlovid period, because similar to the hypertension, some of these are just going to be percentages that are in the population beforehand. So more to come on lots of those types of analyses, and in particular, really looking at other indicators of viral load post-Paxlovid, and really thinking about the interaction in particular with the urinary and kidney systems with Paxlovid. And I think that's the end of our update. Is that right, Emily?
I think so too.
All right. So yeah, so we can take some questions. I see there's been a few in the chat. Let's see.
David mentioning something that we discussed a lot during the period of time when we were performing analytics on this data, that it is very difficult, if not impossible, to determine who is truly a rebounder with the data that we have, because we cannot assess viral load for the most part. There is a very small number of patients that get tests in that of that type in our data, but it's very, very, very small, and we're already dealing with small numbers here. And so every time we work with these data from here on out, we're certainly going to have to caveat that with, you are testing positive post-Paxlovid. That does not necessarily mean you're a rebounder. We're going to use that as a tentative proxy, but with lots of caveats attached.
Emily, can you talk to us a little bit about the association potentially of Paxlovid and how you may associate it treatment with the long COVID? Because I know that there's some folks who are excited about that potentially of whether it's helping or hurting, but we have a time issue right now, at least, and what you guys are thinking about that.
Yeah, so we're really looking forward to being able to report on that. Right now, our machine learning model that looks for patients with potential long COVID requires at least 90 days, rather at least 100 days now, from your acute COVID infection before it will even bother trying to make a prediction on you. And that's because we need a critical mass of data in order to feel comfortable making any kind of assumptions. And because most of the Paxlovid use that we're seeing is in April and later, although there is some before that, it's not surprising that most of the patients don't even have that 100 days under their belt yet. I have a feeling that by the fall, if not sooner, we're going to be able to start seeing some associations, if there are associations. But it's just a matter of letting time pass in order to actually get those data in N3C and able to be analyzed.
And a follow-up on that was when we get the CMS data, and I think a lot of Paxlovid will be outpatient, and I feel like I've been promising the CMS data for centuries, but it hasn't been that long. But when we do get it, and we will, do you see us being able to do a reanalysis, and because we'll have a lot more outpatients at that point, and what are your thoughts on that?
I think that the CMS data will do nothing but help. So right now, for those of you who haven't done the linkage between claims data and EHR data, claims data basically fills in the gaps where EHR data falls short, because it fills in, for example, I get my care at Duke, but I go sometimes to UNC for certain specialties. Duke's EHR may not know about my UNC care, and UNC may not know about my Duke care, but my insurer would know about both of those. And that is true for CMS data for patients that have Medicare, Medicaid. And that data is going to enable us to see, for example, if somebody gets Paxlovid and does end up hospitalized in their post-Paxlovid period, but not at the hospital that they got the Paxlovid at, and things like that. So while I don't know how the CMS data is going to affect our ability to analyze the situation, I know that we will be able to feel a lot more confident in the completeness of our data, at least for the 65 and up population, which is the majority of the folks who are receiving Paxlovid right now are in that age category. So that actually matches up very well.
Thank you.
You know, I'm sure the CMS data could make a huge difference in that.
Absolutely. I want to speak to Warren's question a little bit. I would love to know if there is a different asymptomatic rate between unvaccinated, vaccinated, and boosted individuals. So that's a really good question. There's a lot of missing data, both on testing and on vaccination. So we're really struggling with that. There's some really neat work going on reinfections, as well as on the vaccination that Emily presented. And I think the combination of those two things, if we have enough records and looking at historical controls before the vaccination was available, will maybe allow us to try to get after that question. But it is a really challenging question given the level of data missingness that we have. But I think that the intersection will help us get there. I don't know if anybody else wants to jump on. I see Richard's here. Not to call me, but
I think that's everything.
yeah. All right. Sounds good. Anyway, yeah, yeah. Did we hit all the questions, do you think?
Well, I'll just make a comment about it. And the reason I asked that question is we have is part of Radix Up. We have one project that was doing prospective testing in schools. And it was a relatively small school, but they were testing all the staff and all of the students. And they detected surprisingly, they only had 113 positive tests out of about 3,000 tests over the course of a year. But 90 of those, 87 of those were asymptomatic, which was far higher than I was anticipating. Yeah. Most of them were vaccinated individuals because they were mostly the teachers. But that was an interesting observation, and I'd love to see how that plays out in the broader population, but we don't have the data, to your point. We just don't have it.
Yeah. I mean, and, even if we had, vaccination and like public PCR type testing, like Walgreens type testing integrated through state systems, we'd still be missing all of the home tests, right? So, unless you're tracking it as part of a program like what you're suggesting, it's just so hard.
Well, and those asymptomatic individuals would have had no reason to test themselves. Right. So it would have been. I
test
pretty
myself
random.
all the time.
You're an unusual person. And Emily, I wanted to point out that actually I go to UNC for my general things. I go to Duke for specialties. So that's very funny. We're exactly inverse.
Yes, but you've both been deduplicated by our lovely PPRL system. Perfect ending to the talks today.
That's very good. That's great, Melissa. Okay.
There's one more
let's see.
question
David.
from David for you, Emily. Emily, can you and the team comment on the generalizability of the computable PASC phenotype over time? In other words, what are the predicted rates over time using the current algorithm? Have we plotted that? I don't think I've seen that.
So we have plotted it, but I don't know that Richard, we haven't refreshed that plot yet with the newest version of the model, have we?
We have, but it's still a little bit of a sawtooth. It's hard to really stand behind those precise estimates month by month.
Also,
Yeah.
the other problem too is sometimes sites go in and out of the inclusion criteria because of the need to have higher quality for that. So that's another one of the reasons for the sawtooth sometimes.
Yeah, I mean, certainly generalizability is something that we are really focused on right now. And while I may not have a super satisfactory answer to your question, one thing that I can say that I'm very excited about is that we are now finally, for the first time, having non-enclave users try to run the model in their environments. So we've been working with some of the crew from the All of Us project, which has been really gratifying. They've been wonderful to work with, and they are considering running our model on their data and actually have made great headway on that, as well as some individual sites. And in order to do that, we've had to extract the model code out of the enclave and sort of de-enclavify it, which has been a really interesting but important exercise, because I think, we're all very huge proponents of open science here, and we want to make sure that it's relatively streamlined to be able to take a model that works in the enclave, export it, and throw it on public GitHub, which is exactly what we're doing with our model now. It's actually out there on GitHub, and anyone who is interested in trying to run it locally, just shoot me an email and I'll send you the link. I can put the link in the chat too as well. But I think that's how we're going to achieve a notion of generalizability, is by having folks who are not us run the model and see how it does.
Oh, that's fantastic. So, so I guess there's a change in Zoom, which.
Yes. Hi, everybody. Thank you so much for attending this forum. We will be changing the CU to CU Zoom very soon. We had University of Washington provide Zoom for forum up until now, and that contract is ending. So very soon you will see a new invitation to register to forum. Please be on the lookout in an email and in other announcements soon. Thank you.
So it's the same interface, just different site.
Yeah, different host, same interface.
Wonderful. Okay. All right. Well, thanks. Thanks, everybody. And a great session as always. And we'll see you in a couple of weeks.
Thanks, everybody.
Thank you.
Bye-bye.